So hi everyone, I'm Isla, I'm a year medical student at Edinburgh, and I'm here to talk to you today about my project I'm doing this year, looking at CT imaging in idiopathic out-of-hospital cardiac arrest. So as I say, I'm fifth year, and as part of our course this year, we've given 6 weeks across the year to go off and do a research project that whatever we liked. I think I've got a bit of an interest in emergency medicine, so I found the emergency website online and emailed Matt, who was kind enough to firstly email me back, and then be my supervisor and let me take on a project that he'd been thinking about. So out-of-hospital cardiac arrest is the third leading cause of death in Europe. It's common, get about 3,000 cases annually here in Scotland, and spinal's really bad, about 30 days, spinal rate about 10%. So these patients need treated really quickly, so it's important to find out the underlying cause of their arrest as fast as possible. But this is really difficult to do sometimes because there's a wide range of underlying causes. Patient notes might not immediately be available, so you have a past medical history, and you obviously can't take a history from an intubated patient. So when there's no immediate obvious cause of arrest, we call that idiopathic out-of-hospital cardiac arrest. And that was the patient population that we were looking at. So these are the guidelines from the European Resuscitation Council, published in 2015 and it's their diagnostic algorithm for out-of-hospital arrest. So they recommend first thinking about cardiac cause, considering angiography and PCI, and then once you've excluded cardiac causes of arrest, then think about non-cardiac causes with a CT head or a CTPA to look at neurological or respiratory causes. But despite this, 13% of patients still don't have their arrest cause identified, so idiopathic arrest. So recently, CT imaging has been becoming more common, both as a method of looking for the arrest cause and looking at complications of arrest or resuscitation. So this was a study from 2012 that the ERC guidelines are based on, and it was a retrospective study of about 350 patients in France, and they found that CT head and CT chest imaging protocol found 20% of idiopathic arrest causes. And then more recently, there was a retrospective study in America of about 100 patients, and they found that early whole body CT imaging was possible in this patient group, and they identified pathology. They didn't differentiate between arrest cause and other diagnoses. And then last year, again, American study of 100 patients, but this one was prospective, and they assigned everyone to get whole body CT, and they found 39% of arrest causes, with 13% not being identified by any other investigations. So that was what kind of set off my project, and looking at what we do here with CT. So it was a single centre retrospective cohort study, and our aims were to look at current imaging practice here, with what scans we did and how many scans we did, and then whether or not they went on to identify either the arrest cause or other relevant pathologies. And then looking at if there was a difference between patients who had pathology imaging and those who didn't, and then finding the safety of imaging. So to be eligible, patients had to have a diagnosis of non-traumatic out-of-hospital cardiac arrest with return of spontaneous circulation. They had to have attended this emergency department and been transferred to ICU, be over 14, have a GCS of 8 or less, and importantly, they had to have no objective imaging or ECG cause of arrest on admission. They had to be clinically stable to undergo CT imaging, and they were excluded if they declined further investigation in previous anticipatory care planning. And then this on the right is a section of my stroke recruitment diagram. So over the 4-year period from 2016 to 2019, there were 288 patients who presented with arrest to the department. 132 of those were excluded, basically because there was an objective cause spinal commission, most common of which was acute STEMI, which left 156 patients with a arrest to be recruited to a study. So those patients were on average 60 years old, 29% of them were women, and about 70% had pre-existing comorbidities that could have been relevant to arrest, like heart disease or hypertension or a previous stroke. 27% of them had symptoms before they collapsed, and the most common of them was EF. 32% of them rearrested, with an average downtime of about 23 minutes, and 3/4 of them had bystander CPR. So of those 156 patients, 90% got CT imaging ordered in the department. There was about 195 scans done in total over the 4 years, the most common by far being CT head, followed by CTPA, and then I won't read them all out, but whole body CT only 5 patients got. And then of the patients that were imaged, 4% of them had their arrest cause identified by scan. So CT head found 4 strokes, and then there was 1 case of acute coronary syndrome and 1 PE found on CTPA scan. 37% of patients who were imaged had other known pathology, mostly secondary to the arrest or resuscitation. So hypoxic brain injury is the most common, followed by a bone fracture, and then signs that were likely to represent aspiration pneumonia. Imaging was safe, with no reports of contrast-induced AKI or retrorectance or any other complications reported in the notes. So I then went to look at if there was a difference in patients who had pathologic imaging, so either the arrest cause or something else important, compared to patients who had normal imaging with no findings at all. It was unsurprising that features of a more serious arrest were associated with then showing pathology. So being in asystole, having a longer downtime, having rearrested, and having unreacted on emergency department admission. So back to the original question, which was how does CTP help quickly diagnose the cause of arrest for these patients? Well, only 4% had their cause identified, which was quite surprising in the context of previous research. I showed you at the start, so one study had 20% and the other one had 39%. The important difference was that they had much more extensive imaging in the studies. They looked at CT head, CT chest, or whole body scan. Whereas although 90% of our patients were imaged, actually the most common scan was CT head. So not many of them got scans beyond that. So only 12 of them got CT chest, abdomen, pelvis, and 5 got whole body scan. So maybe that's why we didn't find as many causes, because we didn't scan as much of our patients. So because of that, I went to look at the arrest cause, which is documented in those by the ICU physicians. And I divided them into causes that could have been diagnosed by CT, like stroke, and causes that couldn't, like hyperkalemia. And when I did that, 26% of patients had a cause that could possibly be identified on a CT scan, with the slight caveat that acute coronary syndrome, CT could maybe identify stenosis, but not dynamic acute coronary syndrome. So what did we learn from this study? Well, we now know that 90% of patients who come into the department with an arrest get CT scan, the most common of which being a CT head. And those scans diagnose the cause of arrest in 4% of patients. Actually, if you consider that with other important findings, the scans inform patient care in about 40%. They are identifying indications of antibiotics like pneumonia or antithrombotics and contraindications of that, like hemorrhagic stroke. And although it wasn't something that we could look at in this study, having a negative scan could also be valuable, so ruling out catastrophic brain injury could also be important. While I was doing this study, the ERC published new guidelines. Their diagnostic algorithm is the same, so they still recommend doing a CT brain or CTPA scan. But they published a new list of indicators of current outcome, one of which is diffuse and extensive anoxic of brain CT, which was the most common other finding in the study. This guidance has been incorporated here, the guideline created by Fraser Waterson and colleagues, and I've just taken some screenshots from their guideline to show the recommendation for CT head and CTPA counterpoint and cardiac cause, which quite nicely fits with my results, with those scans being the only ones to identify rest causes. And that's again the list of indicators of current outcome. So next steps for the study could be to try and further characterize the patients that go on to show findings, with the aim of then being able to develop a scoring tool to say, you know, this patient should get scanned, this patient shouldn't, hopefully with objective measures that would be easily available, like arrest rhythm, that you might have in the acute setting. Nothing much to say, so just thanks to everyone who helped me. Dr. Easterford put together the database of patients presenting to the department. Everyone, including the setting and Nick in particular, helped me out, and thanks to Matt for taking me on, and I've really enjoyed the project. Yeah, thanks for listening.